Hello, this is Dr. Eduardo D'Alessandro from Brazil. This is a video comment for our 12th week on the PPCR 2021. This week we've been studying how to establish an adequate sample size. And we've seen some strategies, and I would like to comment on the minimal clinically important difference, the MCID. It was defined by Jaeschke and colleagues in 1989 as the, and I quote, smallest difference in score in the domain of interest which patients perceive as beneficial and which would mandate, in the absence of troublesome side effects and excessive costs, a change in the patient's management. The term minimal important difference, MID, is now often used to avoid the focus on the clinical importance of change. The general idea of the MCID is that it defines the lower threshold for change that is important or valued by someone. This could be the patient, the healthcare provider, the researcher, the funder, or policymaker, and all other stakeholders. And ideally, this change should surpass the boundaries of measurement errors to be interpreted as change. Values of MCID can be determined for different settings and applications. They can be designed for group-level applications and also for clinical care, individual-level application. MCID values may differ depending on its application and on how the MCID value is derived. For most measures used in clinical practice, little effort has gone into defining the MCID, and according to Jaeschke, the reason is that through repeated use, clinicians develop an intuitive sense of the MCID. Experienced clinicians would have no difficulty specifying that a 10% drop in diastolic pressure in a hypertensive patient is clinically important, whereas 10% improvement in spirometry parameters in a patient with COPD is of borderline significance. They are able to come to these conclusions after seeing the changes in function and in clinical course that correspond to the variations in test results. Experience with a test or instrument is a feasible and valid method for determining the significance of changes in instrument score. Trouble begins when the instrument is for research purposes and the audience is not familiar with their clinical use. In such scenario, something more rigorous than, in our experience, the changes are clinically important would be more desirable. A variety of methods have been proposed and used to quantify the MCID. These methods can be grouped as three main approaches: the anchor-based, the distribution-based, and the expert opinion-based approach. The anchor-based approach uses the anchor, which is an external, tangible marker of change. Many anchors have been proposed, including objective and subjective indicators. When using an anchor-based approach, the subject rates himself or is classified by the investigator, and a priori determination is made of what is to be considered important change on this anchor. After, the change score on the target questionnaire that relates to this threshold of important change is calculated and reported as the MCID. A few factors influence the anchor-based approach. For instance, Which methodological and statistical approach should be used when calculating? The intrinsic variability between patients and also within different measures of the same patients, the timing effects on testing and the recall bias, the direction of change that defines its importance. Is it improvement or is it deterioration, the change? The actual choice of the anchor, is it a hard endpoint or a subjective one? Also, whose perspective determines the change magnitude? Is it the patient's, the family, the caregiver, or the clinician? The second approach are the distribution approaches that use internal quantifications and statistical variability of the sample and also the magnitude of effect of your intervention as a proxy to MCID quantification. Distributional approaches provide a starting point to determine the interpretation of change through defining the noise that must be surpassed to interpret that the change is important. These methods are not encouraged as a sole method for MCID derivation, despite they are simple and they are quite utilized. The use of mathematical analysis of sample distribution is controversial and has been shown to be inconsistent as a proxy for change. Also, this approach do not verify concepts of important or meaningful change, and therefore they are not the ideal instrument. The opinion-based approach is where consensus-based methods, such as the Delphi method, are used to either quantify the MCID or choose the final MCID value from previously developed MCID values. Whose opinion is used is based on experience knowledge or data. And again, the value will be influenced by whose perspective is used. Another important consideration is the nature of the data itself. Many scores bring out ordinal variables, and some suggest that much of the variance in the MCID determination is caused by this lack of interval level data. The solution to that would be moving toward item response theory, IRT, scoring to the items included in a questionnaire. The item response theory scoring perspective is used instead of the sum score of the questionnaires, thereby producing a scale that should hold meaning in its intervals. This approach still lacks evidence for its use, and there is no certainty of its superiority. Well, to summarize, MCID is a variable concept. There can be multiple MCID values for a given measure, and not all methods result in comparable values, nor can they be applied universally. It is recommended that MCID values be based on anchor-based methods, as distribution-based methods do not estimate importance of change, but instead they estimate the measure noise. Nevertheless, anchor-based approaches require deciding on the anchor, defining cutoffs, and choosing the statistical approach. And all of this will influence its applicability and significance. MCID is far from reaching a consensus, yet it gives further information in understanding the meaning of change in a given scale. Hey, cheers, thanks for watching, see you next week, bye bye.